Turning points change the course of our lives, whether it's a big decision, overcoming an obstacle or tragedy, or taking a leap of faith. These stories of inspiration and resilience are what Turning Point is all about. Hello, everyone, and welcome to this week's episode of Turning Point. I'm your host, Priya Sam, and this week we have Dr. Naheed Dosani with us to talk about his Turning Point story. Naheed is a palliative care physician and a health justice activist. He is also the founder of PEACH. That stands for Palliative Education and Care for the Homeless. It is a service that supports homeless and vulnerably housed patients with life-limiting illnesses. We're going to talk more about PEACH and how it came to be in just a few moments. Welcome to Turning Point, Naheed.
Thank you so much for having me on, Priya. I really appreciate it.
Oh, it's so great to have you. And, before we get to your Turning Point story, we have heard so much about the toll this pandemic is taking on healthcare workers like yourself. So how are you doing?
Well, thank you for asking. It's not often that people ask, and my new kind of baseline answer is I'm pandemic fine. I guess it's just like a better baseline than, how are you? Yeah, I mean, given, the various roles that many health workers have been taking on, people are working, longer hours, more shifts. People are just doing more and dealing with much more than they ever did before. I'm working in street-based outreach, providing palliative care for people experiencing homelessness, which I know we'll talk about. But I'm also the medical director for the Region of Peel's COVID-19 isolation and housing program, and so that's put me at the forefront of this pandemic, and has allowed me to see the ways that this pandemic has disproportionately impacted different communities. My colleagues across Canada are dealing with a lot of distress, moral fatigue, compassion fatigue, and even grief. And so it's been a trying time for health workers everywhere.
Can you tell us from your firsthand experience? I know we hear a lot about how this pandemic is disproportionately affecting our vulnerable populations, but what are you seeing there on the front lines?
I'm seeing the fact that this virus is not an equal opportunity virus by any means. I'm seeing and have seen the ways that we may have all weathered the same storm, but we have not been in the same boat. Actually, some of us have been in yachts thriving, while the rest of us have been in life rafts barely surviving. From racialized populations to essential workers to people experiencing homelessness to people with disabilities and elders and seniors in our communities, this virus hit these populations especially hard. And one has to wonder that in the first wave, maybe there was an argument that we didn't know, and we didn't have those learned lessons. But when the second wave hit, it wasn't really fair to say that the same thing. That said, I've seen an incredible resilience among our seniors, from essential workers, from many of the populations that I'm talking about today, to kind of roll with the punches and to show real strength during this time. I think it's shown a lot of lessons about how we can better support vulnerable populations in the future, including upstream social policies around housing, around basic income, and how we can improve our long-term care system, for example, to better support frail seniors in the future.
All of these topics and areas that you're bringing up here, and your focus on these vulnerable populations during COVID-19, it really ties into a lot of the work that you have been doing throughout your whole career, really. And of course, this pandemic, it sounds like, is really adding another layer of that and bringing a lot of this to the forefront. But let's go back to where this all started. It was about 10 years ago during your residency, when this big turning point really led you to the work that you do right now. So take me back to 2011 and tell me what happened.
Well, thank you so much for asking, and it's one of the reasons I really love the way your podcast works, because it sometimes life does come down to a few key moments or a turning point. And so for me, I was working as a resident trainee at the University of Toronto, working at a local men's shelter, providing healthcare for people experiencing homelessness. And a man showed up at the door. He was in crisis. He was in pain. He was writhing. He was shaking. And it was because when I looked in his mouth, he had this tongue cancer that had spread throughout his face and head and neck. And as I began to know him and read through his medical chart, I started to realize that he was diagnosed 1 year before in a local cancer center. But due to his mental health, he had a long-standing diagnosis of schizophrenia. He was not able to organize himself to go back for follow-up and treatment of his cancer. As time went on, he started to experience pain. So he did what any one of us would do. He went hospital to hospital, ER to ER, walk-in to walk-in, seeking the kind of pain control that any person should have access to. I saw the notes when he would visit these emergency departments and hospitals, and I could see that he was seen and then denied access to pain medicines. Maybe it was the way he looked, maybe it was the way he smelled, maybe it was what he said, maybe it was what he didn't say. But I felt that there was some sort of judgment happening about him when he was in these settings. So he presented in our shelter that day in pain crisis, and he was in our care. I tried to build a connection. He promised me he would take some pain medicines, and we'd go back to the cancer hospital to even work to get some radiation to shrink the tumor that was now so big. And he promised me he would do that. I got to the shelter the next day. I couldn't find him anywhere in the morning. Actually showed up early because I was so excited to get going with him. And I couldn't find him in the hallway or the cafeteria or anywhere. And a friend from down the hall, one of his friends, said, "Hey Doc, are you looking for Terry?" And Terry was his name. And I said, "Yeah." And he said, "Oh, you didn't hear? Terry died last night." Terry's body was found in the early hours of the morning by a commuter on her way to work. It was too little too late. He had overdosed on a combination of alcohol and street drugs. This was a very traumatic event for me. I mean, don't get me wrong, medical trainees are often encountering death in our training, but this was different. This was a person who had fallen through the cracks again and again and again in a city that has world-class cancer care and world-class palliative care, which opened my eyes to the lack of access around palliative care for people who experience vulnerabilities in our communities. And I guess you could say the rest is history after that.
You tell this story as if it was yesterday. I can tell, how deeply it impacted you, all of the details that you remember about Terry. And for you, I believe, took some time off after this to reflect and do a lot of research. And what did you find out during that time?
Yeah, I given the traumatic nature of the event and the way that it was hitting me, I was dealing with a lot of grief at the time, not just because I lost a person I cared for, but because I was living in a society that allowed this to happen. And in the time that I took away, I learned some things. I learned that people experiencing homelessness are 28 times more likely to have hepatitis C, 5 times more likely to have heart disease, 4 times more likely to have cancer. I learned that the average life expectancy for people who are housed in this country is 77 to 82 years old, but people who are homeless or experience homelessness, their life expectancy is 34 to 47 years old. I learned that people experiencing homelessness die at a rate that's 2.3 to 4 times higher than the average Canadian baseline population. Basically, people who don't have a home or live in the streets and in shelters, their life expectancy is half as compared to you and I, Priya. And so I started to realize that homelessness was a terminal diagnosis of the social factors that make us sick, the social determinants of health. And so I worked with colleagues at the Inner City Health Associates in downtown Toronto to inspire a new way of thinking, a new model of care. And we launched, in 2014, the world's first mobile palliative care program that focuses on providing healthcare and palliative care for people experiencing homelessness with serious life-limiting disease, so that no person falls through the cracks, whether they live in a shelter, supportive housing, a rooming house, or under a bridge, so that people who are living and dying on the streets have supports and care, no matter what their goals and what their wishes are.
Wow. I mean, this is such a testament to how deeply the Terry story really affected you, because you not only did finish, obviously you finished your residency and went on to be a physician, but during this time, I mean, I think we've all heard stories from people about how grueling residency is. But during those next few years, you also managed to found this organization that is thriving now. And other cities across the country and around the world have also modeled programs after Peach.
Yeah, it's wild to think about it, but when you reflect on that turning point, it hit on so many levels that it inspired me to even alter the direction of my further medical training. I'd always envisioned, doing other specialties, maybe like emergency medicine or even more like a public health focus. But after that, I was exposed to palliative care and the ways that inequities exist in the ways people are dying in our communities. And if we can't get that part right in our society, like what's the point of all this, right? So access to palliative care is a human right. Access to housing is a human right. So there's an overlay of injustices that made sense. And that inspired the creation of this program called PEACH, Palliative Education and Care for the Homeless, which has now evolved into a mobile street and shelter-based palliative care program that cares for any time between 110 and 120 clients on our caseload. We're a 24/7 model. We feature a team of health navigators, nursing coordinators, home care coordinators, and staff, physicians and psychiatrists to really support the needs of people. And we're now part of a national and even international family of programs that have developed in Victoria, British Columbia, Edmonton, Calgary, in Seattle and even Brisbane, Australia. So it's been really neat to kind of be part of this new kind of like way of thinking about how we deliver care. And but to me, Priya, it really boils down to one thing. It boils down to meeting people where they're at. That's really what it is, right? It's that trauma informed care, and yeah, that's kind of what it is in a nutshell.
Yeah, and between your work with Peach and also your work as a physician, as a palliative care physician in a more traditional setting, what do you see as differences in the way people react when you kind of meet them where they're at, as you say?
I think sometimes people may be surprised about how people react when we offer them care through the PEACH program. You have to remember that the kinds of people we care for are people who've often faced trauma and discrimination within healthcare institutions, within government institutions, and in our community in general. Just think about the stigma that exists around people experiencing homelessness. There's a deep-seated fear, and I think sometimes a deep-seated hatred in a country like Canada for people experiencing homelessness, as sad as that sounds. That's why conversations like this are important, because we need to destigmatize and deconstruct the myths that exist around people experiencing homelessness. For the record, I've never met a person who wanted to be on the streets or in shelters. People are in these situations due to a complex, set of circumstances. That are created around due to the structural arrangements around them, due to a weakening social safety net, due to a lack of supports around social assistance, housing, medical care, from federal, municipal, regional, provincial politics. It all kind of connects in many ways. So many of the people we care for actually are shocked. They think there's like a catch. They even think it's a scam sometimes. Like, what? You're just gonna come check on how I feel, my quality of life? Nobody's like even checked on me for like 2 decades. Like, you're going to spend more than 10 minutes with me, because we typically spend quite a bit of time with people. We see people over and over. We go to wherever they are. They've never interacted with a health model like that, and so they're just blown away usually. And even we're shooed away a couple times because it's happened because people just don't believe it, right? Like, but we come back with respect and we offer an opportunity, and then people are like, oh, this is real. So that's actually the reaction we usually get: surprise. And that's sad to me, that we've created a society where people are surprised when they get that kind of care, when we meet them where they're at.
Wow, it's just such a powerful story, and really opening my eyes, and I'm sure the people who are watching and listening as well, to I think something that many of us have just never thought about. We really take for granted how lucky most of us are to be able to have access to these services that we've kind of come to expect, and also to have some sort of amount of trust in the healthcare system. So, thank you for the work that you're doing, for sharing all of this with us. I also do follow you on Twitter, and And I know a lot of other people really learn a lot from your posts. You share a lot of really valuable information, a lot about vulnerable populations, like we've been talking about, and you also talk a lot about racial injustices in our healthcare system. Was this something that you were aware of before you yourself became a physician?
I think, it's important to, ground myself in the ways that I was kind of like brought up. I'm the son of two refugees who came to Canada in the 1970s from Uganda, a war-torn country fleeing persecution. And so growing up as a child of two refugees who went through the immigrant experience, poverty, social justice, and the social determinants of health were huge parts of my upbringing, and definitely the consequences of racism and a firsthand understanding and experience in systemic racism. And since getting into medicine and healthcare, it's been really hard for me to ignore or look away from the fact that actually racism is very much present in healthcare, and the product of systemic racism is something that is very real in our communities. And so, as a physician, I now have this privilege, and I try to utilize this privilege where possible to push forward discussions around racism and the consequences of systemic racism in our communities. It's a necessary kind of thing for me, and it's part and parcel of the work. And I think you don't have to look any further than COVID-19 to see the impact of systemic racism in our communities. When the first wave happened, we were told by government officials and many elected leaders, you don't need race-based data. It's affecting us all equally. We pushed, activists were pushing. Finally, we got the data, and lo and behold, 83% of cases, COVID-19 cases, were among racialized communities. Why did we have to fight for that data? Even to this day, nearly 70% of those hospitalized are racialized people in a city like Toronto. This is Toronto data, but this is actually true in cities across Canada. It's pretty much across the board. That's just like around race-based data. I mean, I can go on and on about, the examples of systemic racism in healthcare, from police brutality to the way we hire nurses and PSWs in our home care system. We're often racialized women, to the way we treat particular disease states, particular patients, like people have sickle cell disease, and the way we treat Black patients, dealing with that, to the longstanding health disparities that exist around Indigenous communities. It's through and through. We have a lot of work to do. It's important. It's important work. We need to keep this going.
And you've certainly been a big part of doing that, of highlighting some of these issues. You are very vocal and clearly very passionate about your experiences and your opinions. I do wonder, how do your colleagues react to this? Like, has this ever caused you any issues at all, work wise?
I think it's important to say that when having these conversations, you need to be conscious of the fact that these are my opinions, and when speaking with media, I try to make it very clear. I'm not speaking for my employer. I'm not speaking for um, the hospital I'm at or the community health organization I'm affiliated with. So, I think, that's one piece of it. But I think by and large, believe it or not, community members have been health community members and my colleagues in hospital have been very supportive of the work. Um, I think one of the pieces that's really important is being a health communicator. My role is to convert a topic like systemic racism and make it digestible and more understandable for people who work and deliver healthcare, to understand how it's relevant to them. So, when it comes to, I mean, COVID-19 is a health issue, so a lot that's it's rarely like translatable, and that's probably why we're talking about it a lot more. But like, why is police brutality a health related issue? For example, I mean, we see the disproportionate impact that policing has had on communities of color, Black and Brown communities in particular. People who deal with mental health crises, for example. That's been a real project for me. I'm a co-founder of Doctors for Defunding Police, but also encapsulating advocacy around other movements as well. During COVID-19, I helped co-found Doctors for Justice in Long-Term Care, to respond to the fact that we at one point during COVID had one person dying every hour in Ontario's long-term care homes. And there are many reasons for this, including, the ways that for-profit long-term care has derived more deaths. And this is like totally something that's not been looked at by our governments appropriately. It needs to be. But also, secondly, the fact that many racialized women work in long-term care and have precarious employment. So, it's a lot of like converting, and once you convert it and kind of like translate it into a health-related message, colleagues are there and tend to support. There are trolls. There's lots of trolls actually, and there's COVID-19 has brought more trolls than ever before. I've received threats that have been very real. So it's been a journey for sure, and I hope it's just the beginning of that journey because I'm not going to stop.
I did wonder about that because I know, anytime you are putting out information, and like you said, there have the amount of trolling does seem to have increased over the course of this pandemic as well. But you are obviously still, holding strong and still very committed to your message. Has there ever been a situation, whether it's at work or with a troll, that has made you hesitant to post anything else or to share more information?
Particularly when we had the events of last summer around Black Lives Matter, and the George Floyd incident, and then when we founded when we founded Doctors for Defunding Police, I was taking on white supremacy in Canada and white supremacy issues. I started to get a lot more trolling and threats then. When I started to point out the inequities that existed around how police handled the Adamson barbecue incident in Toronto, a famous restaurateur in Toronto that defied public health guidelines and opened the restaurant anyway for indoor dining when he wasn't allowed to. I got a lot of threats then too, believe it or not. And actually, yeah, like I got threats, and you start to make a decision at those points about you know what you're saying and the impact it's having, and um, you know I've had to go to the authorities from time to time about things. Nothing has ever come of that, and I find with these things people tend to be anonymous. They tend not to have their personal information, but I've also started to realize that when it happens more, it also means you're striking a chord. It means your message is hitting. It means that it's resonating with the people that it needs to resonate with, and it's making people uncomfortable. And it's a badge of honor, is how I kind of describe it. It's not a perfect world. It's unfortunate that people, racialized people who are standing up for health equity and equity in general in our communities are getting targeted. But I'm not the only one. All of us have gotten threatened, even just for standing up for science and evidence-based public health guidelines has made you a target. Can you imagine if you're taking on white supremacy and racism at the same time? So like it's just to put it in perspective, right?
Yes, and in a future episode, I want to ask you if you ever sleep because I don't know how you do it all.
Thank you. I actually do sleep. I sleep quite a bit, and I binge watch a lot of like streaming television shows, and I'm a huge fan of like different series and different shows, and I'm binge watching For All Mankind on Apple TV right now. It's so good, and so yeah, believe it or not, yeah, totally.
So somehow you do manage to do it all. I'm impressed. Okay, and I need to watch that show. I've heard a few people say
It's
that it's
so
really
good.
good. You mentioned Doctors for Defunding the Police, and I wanted to ask you a little bit about this because you, as you said, are one of the founding members, but you actually have hundreds of doctors who are on board and who have signed a petition of support for your mission. So what led you to kind of start this initiative, and I guess what are some of the main things that this particular group is focused on seeing change?
For sure. I think at the outset, the Doctors for Defunding Police movement is about recognizing that policing is a public health crisis for our communities, and particularly hardest hit communities, including racialized areas and neighborhoods. We now have over, I believe it's over 600 signatures. So it was a campaign that started with like 55, doctors, academics, researchers signing it, and then it kind of like totally grew. And it really asks the question of starting to look at policing as a public health and community health issue. It looks at particular particularly the evidence, which indicates, Black people, in a city like Toronto are 20 times more likely to be, shot by police than white counterparts, for example. We see significantly similar data in places in other cities across Canada around Indigenous communities as well. And so we are looking at defunding the police, which sometimes people get their backs up against the wall, and there is some argument about like, okay, like how much, like to what level, to zero, and to 50% to 25%, like, and so our request was upwards of 50% was what we were talking about. But we're not just talking about, like, it's not just defunding the police, it's then reallocating that funding into social services and community. And in many cities across Canada and actually across North America, we spend more on policing in these cities than we do on housing, on mental health, on addictions, on social supports, which doesn't make a lot of sense. And if we actually use that money to do this, we could actually do a lot better and support people. And we have seen, excellent, representation of the defunding the police movement across North America and around the world. And just recently, we saw progress in cities like Austin, Texas. And so, and there's many more. We can really encapsulate a healthier society where, Black and Indigenous people specifically are not targeted by police. And you asked me, like, what got me into it, because I was sick and tired of seeing the people I care for, my patients, my clients, getting targeted by police. Black and Indigenous people dealing with mental health, dealing with poverty, dealing with homelessness, and being, disproportionately targeted by policing. And I saw this with my own eyes. And I resonated with the public health messaging around it, and decided we needed to do something. And this was our response, around the George Floyd incident and around Black Lives Matter last year.
And since founding this movement, have you seen any changes? Like, has government or have any officials been willing to talk about steps towards making some of these initiatives happen?
We've seen, cities across Canada start looking at this discussion. I've seen, defunding, counselors put in motions to defund by 5%, 10%, the 20%. And I think we're at the stage where people are talking about, percentages. We have not seen a response that matches the demands in our letter. We've also not seen really broad sweeping examples of the kind of defunding and reallocation of funds that we're hoping for across Canada. And it's important to kind of talk about this. And I'm glad we are, because movements changed, that was very much we talked about that in a lot in 2020, and now we tend to be talking about different things. So the Doctors for Defunding Police a movement is a movement to keep the movement going and keep the conversation going. Racism and policing is still very present. We're just looking today at the headlines. You can see that the Ontario police, the OPP, have been asked to leave a community in Ontario, and the First Nations chief there actually asked them to leave because the trust is broken. Can you imagine asking the police to leave because it's more harmful than helpful? I mean, this is like literally today's headlines. So there's so many things that are still happening, and we're just trying to keep the message going and support various colleagues in different disciplines who are working in anti-Black and anti-Indigenous racism, and to improve policing and really transform policing as we know it.
Yeah, it's really interesting to hear about this ongoing work, as you say, because a lot of times when there is a big event that does get a lot of attention, you tend to see a lot of organizations responding, and then we move on, right, to the next thing that comes up. So it is really, it's just so interesting to hear about this ongoing work that Doctors for Defunding the Police is doing. And as you say, it's not an issue that's gone away just because maybe we're talking more about vaccines or whatever the issue of the day is at the moment. It's still an ongoing issue. I kind of want to take a step back to something you had mentioned earlier. You mentioned that you were, or that your parents were refugees. How old were you when they came here from
Oh,
Uganda, or were you born
I was
here?
actually born
You were
here.
born
Yeah,
here.
yeah,
Okay. Yes.
yeah.
Okay. And did their experience at all influence your decision to want to enter medicine?
I think their experience and their struggles they experienced, working multiple jobs, living in poverty at different times in their life and then in my upbringing, inspired me um, to really rationalize an approach to life which was really based on social justice. And I didn't really know that that would happen through healthcare, but I knew that I needed and wanted that to be a big part of what I did because I felt that we could transform our communities to do better for people, like myself, who was born into a household like that, but many others as well. As I went along the journey, I started to realize that through health, there was an opportunity to derive justice, health justice, and that actually this is work had been going on for a long time. You think about colleagues who have done excellent work, for example, with like Doctors Without Borders, Medicine Sans Frontier, like just incredible work internationally, Oxfam. And I know so many colleagues who work in international and global health who have done great work. But then when Terry died from me in my residency, it it showed me that I think it's really important that we do work internationally. I probably will do work like that in the future, myself, but I realized that in our own backyards there were huge inequities. Like you have, people getting world-class healthcare in these like, hospitals with like marble floors in the lobbies and just like beautiful, and then literally one block away there's a shelter for people experiencing homelessness, and the life expectancies are like 77 to 82 years old in this hospital and like less than 47 years old in this shelter. And that to me just doesn't make any sense. And I started to realize that, the disease of housing, the social disease of a lack of a roof over your head, actually is a health condition, a social health condition, and that we can improve it with income, with housing, with social supports, with emotional supports. And then when you top off the experiences with Terry around the lack of access to palliative care, you know, a specialty of healthcare which aims to support people with serious life-limiting diseases around medical care, around quality of life, around emotional supports. I couldn't help but go in that direction. So it was kind of like the turning point, what just kind of potentiated what my previous life experiences were, and it was just like like that, like whoa, just like mind blowing. I always say to people like sometimes it's not like one turning point. It seems to have been for me, at least for this life stage, but it can be a series of turning points. It can be the culmination of a series of events which becomes a turning point, like, you know what I mean. I think for different people it's different things, and that's just kind of how I rationalize it, at least right now.
Yeah, I mean, it's fascinating to hear about some of your childhood experiences too, because it sounds exactly what you said there. It's like the seeds were kind of planted early. And then, especially Terry, what happened with Terry, it sounds like that really kind of, I guess, allowed some of those social justice interests and some of your passion there to really blossom, and for you to find a way to channel it into an area where you could really make a difference, and to also really be you were really an innovator in this space of providing palliative care to people experiencing homelessness, because I think you even mentioned in our first call that you had gone looking for resources and a program that maybe you could bring to Toronto, and it just really didn't exist anywhere else.
Yeah, and I'm forever grateful to the inner city health associates who gave the program and the model a home, even when it didn't necessarily, exist anywhere else. But also to colleagues who, there were some spaces where I was turned away from, and some people who thought this wasn't necessary or resisted the concept because it was different from how healthcare was delivered otherwise. But there were many mentors, many colleagues in community care, in hospitals, in government, in health policy, who gave it a chance. And I think sometimes um, it's important to give new ways of thinking a chance. And I was coming out of school, so it was even more challenging in that way. But why I think it was ultimately successful is because when we launched, we spent quite a bit of time before listening to the community, listening to people with lived experiences of homelessness around what their palliative care journeys were. Many of these people were dealing with, illnesses themselves or had been caregivers, and so there was a lot of wisdom and a wealth of experiences in that group, and that really shaped the way the program is delivered, how we, describe palliative care, to how we even, staff our team, to who's on the team, to what the skill sets are. And I think you never go wrong when you go back to what it's all about. Like, there's a lot of distractions in life, funding, programming, communications, public relations, but you always got to go back to what it's all about. And that's meeting people where they're at and serving the population you serve. And I always say to the team, whenever we're kind of like struggling, we got to go back to what it's all about. And if you do that, you'll never go wrong.
Well, we are so lucky to have someone like you who persevered through getting those no's along the way, to really push forward to create this program, to find an organization that would get on board. I know so many lives have been improved because of the work that you're doing, and I do actually want to put you on the spot a little bit here because as we kind of look back on your turning point, it's been 10 years now since Terry passed away, since you had this life-changing event that led you to found Peach. What are you most proud of that you've accomplished in the last 10 years since that happened?
Thank you. I'm really okay with being put on the spot, especially when it comes to this, because there's a lot to be grateful for when you think about it. And I know, a lot of the conversation we've been talking about me and my experience, and I'm honored. But more than anything, what I'm, grateful for 10 years later is the community of support that this work has inspired. Um, there wasn't a lot of discussion about palliative care for people who experience inequities 10 years ago. There was some, but it was very focused and very specialized in certain areas in healthcare. And now it's something that's being discussed broadly. I'm grateful to colleagues at the University of Victoria, including Dr. Kelly Stajahar and her team. There's a research team that looks at this. Like, that's what they do. They've put out multiple papers and reports, and I'm honored to write with them and be part of their work. I'm inspired by colleagues like Dr. Kara Bablitz and Dr. Simon Colgan in Edmond and Calgary and Edmonton, who've launched, their mobile programs in their cities that support people experiencing homelessness. And I'm so grateful to the team that we work with here in Toronto, but mostly to the community of people with lived experience who continue to guide us and continue to, resonate with the work, because this work has then inspired discussions about, well, how are we supporting people in hospital who deal with serious life-limiting disease? Should we create more beds for people experiencing homelessness so they have access to die? To, are we doing home care in an equitable and safe way? To, harm reduction and supporting people who use drugs as they die, like they still deserve access to palliative care. To, how are we supporting communities with severe and persistent mental illness? And what I'm saying is this kind of area has spawned way beyond like a model of care, a mobile palliative care program for people experiencing homelessness. It's now it's a field of study. There's a chapter in the palliative care textbook coming out later this year, and that's not me. That's like this community of support. So I'm grateful for that 1 decade later, and it makes me think, where will this movement and where will this work be 5 years now from down the road, 10 years down the road? Like, it just gets me really excited and really enthusiastic about thinking about the future, and the next generation of clinicians and nurses and doctors and health workers are so excited about the concept. Like, I'm not like I don't I'm cool, like, like I'm just want to watch this just like evolve, and it's going to be amazing to see.
Oh, well, and just hearing and seeing your passion for the work that you do. I mean, we are so grateful to you too for the work that you do, for the messages that you share on social media. And for anyone listening and watching, I really encourage you to follow Dr. Dosani on Twitter, and to listen to your TED Talk. I was so inspired by obviously you told Terry's story, and really talked about the founding of Peach there as well. So thank you for sharing your time with us today, for your ongoing work that you're doing on the front lines, and through your health activism as well. I really appreciate it, and I look forward to having a conversation with you again down the road.
Thank you so much. I really appreciate conversations like this. And thank you for creating a platform to do that. I really appreciate it, Priya. Till we talk again.
Yes, absolutely. And thank you to all of you for watching and listening. We hope you'll join us again for our next episode of Turning Point. And until then, take good care of yourselves and of each other.